Here, I want to show what I see and how we got to these records. So first of all, we took with a border lock tray and or this inexpensive polyvinyl, which is like
is that the alginate replacement?
Yeah, but it's basically 12. It works out to about $12 an arch impression in material costs. Okay.
Status blue? No.
So no, it's another one that we found that actually is also a polyvinyl, has the exact same shrinkage rate, pal. But this is more of a heavy body. The status blue is, I feel it's even more viscous. Originally.
Flows.
It flows, and but in any event, just for material cost. But this was a heavy body, and I marked the hamular notches. So you look at the valleys, the deepest valleys, and that's what this border lock tray does a way more effective job than a traditional rim lock tray. It doesn't allow you to catch that as well. Okay, then after we poured that up, now we got the HIP mount. Those same landmarks are right there. Okay, and now you can see here exactly, this is the HIP mount and how it relates to the teeth. Now if we have a look here at Cipra's smile to verify, you can kind of see her right side is significantly up, just like it is on the Aculiner. Her left side is relatively in a nice plane, just like it is on the Aculiner here. So this is what verifies for us why a picture like this is so important. Okay. Now here's something else, a really cool image. I'm just gonna back out of here and show you, because when we do this, Jackie and I always do what we call a digital stick bite. Now, what is it? This also verifies, we put that cross through the horizontal plane, through the pupils, and now, voila, we see this parallel plane, how far off this is down here. Now, we have the means to stretch this down, but this also shows us that this is very, very close.
So now, did you just put a grid on your face? Okay.
Right on this,
That's perfect.
It's right on this, this dumb iPhone, right?
Stuff, yeah.
That's great.
And we use this all the time to verify, okay? Now, I'm gonna cross-reference over to here. Now, this was the correct mounting, Dennis, you did for her. And it really does emulate the same thing, okay, as the Aculiner did, the HIP mount, okay? Very, very similar mountings. So that was the one where you leveled out, made it perpendicular to the pupillary plane.
First contact.
Now I'm gonna show you the incorrect one, where what we find most coice doctors that use it, they do. They for whatever reason, they don't get this perpendicular plane to the pupil plane, and we get bites that are similar to this, okay? Where they have the whole table touching, and this is not the same.
That's exactly what we're trying to prove.
This is not the same mount. And literally, we're hogtied because most of the time we never get these four pictures. We never get these. And
let me just do this.
And that's why these pictures are so important to us. And here's just a natural smile. And we did this just like 5 minutes ago. This is retracted smile with teeth slightly apart. And there's the Emma. We're always looking for 2 to 3 millimeters. And then, of course, tooth display. And that's the E. That's as high as Cipra can go. And she shows really limited to no tissue there. So we're not really concerned.
Low risk aesthetics.
Low risk aesthetics, okay? So now here's the system that you were talking about, the next level that we assess, Dennis, is we're always looking at how does this relate to the level plane of occlusion? Well, we can see the less than ideal level plane of occlusion. But how do we kind of quickly figure out how that will look, or how do we correct that, whether orthodontically or with restorative, okay, wherever the patient's at. So what I'll do is I'll just do a quick overlay of soft wax over the bicuspids and molar, and you can see here where we're dealing with, okay? So this gives a very, very quick synopsis of how to level this plane to a skeletal plane. So everything is working. It's what we call a triplanar analysis. Actually, that Dr. Bob Walker, he's a chiropractor. He was one of the first guys I ever heard that term before, a triplanar analysis. So, and then now we're going to take let's just say this was the phonetic bite that you took here, Dennis, for Cipra. And this is this was just a starting position. Okay, this is not maximum medical improvement, but this is our therapeutic position. And this is with a Shimbashi measurement of, this is actually 16. This is 16 because I reduced it down a little bit. Okay,
that's good for the day appliance.
Right, exactly. So, but if this was the final result, if you were going to move this down orthodontically, you know exactly where you'd want to erupt these teeth to get to the nice level plane of occlusion. Okay, you know already where it's got to go. This would stay the same. This would bring down. This would bring down a little bit, and you would bring this quad up. Now, restoratively, same idea. If you have the patient that is, I'm not doing ortho, and I know you have those patients that are in their 50s, 60s. I'm not doing ortho. I'm not going through 2-3 years of this. I want to restore my teeth to this optimal position. That's how you can map it out, what you have to do. Okay.
Now, tooth alignment and tooth position, when you look at it laterally, you can see that the laterals and the centrals are retroclined. So if you were to take a ceph and have it traced, the ideal angle of an upper incisor to lower, upper incisor is 102 degrees.
Yes.
Okay, to the SN plane. Those look like they're about 95.
Right.
So you're like this, okay, which matches what we saw earlier. So now you have two options. You can do this with ortho, or you can do this with surgery, because those centrals have migrated incisally and your gingival margins are more incisal. So by doing ortho and intruding those centrals, creating interocclusal restorative space, instead of restoring the whole arch back and front, you're probably going to do 4 upper veneers and 6 or 4 lower veneers.
Yeah.
That's it. As opposed to the whole build-up. Because doing it this way, if you don't do ortho, you're looking at some type of restorative intervention on every tooth. So it's up to the patient. Okay. The least risky one is ortho and 4 veneers or 8 veneers, something to that point.
And I was saying to Cipra there earlier, Dennis, the thing that concerns me, when I see an Emma pose like this, I don't want to intrude those teeth. When I see Emma, a nice youthful look, you display 2 to 3 millimeters of tooth.
But the problem here is that she has worn down those centrals and they have over-erupted to contact the lowers.
Okay.
If you look at the gingival margin, this doesn't fit any of our biological principles.
Right.
That gingival margin has to be the same height as the cuspid.
Correct.
So
now, can't you just gingival?
No, that's full-on periosurge. So then you're exposing cementum on the tooth.
Right.
And then you're down to a full coverage crown, because you cannot bond a veneer on cementum.
And so that's why you would rather intrude that and then lengthen it back to that.
Yes, and you can lengthen it. You're not going to like this with either composite bonding
Yeah.
or veneers.
Right, that's
Okay,
fine.
I like the veneer. Because the most predictable aesthetic results will be veneers from 1.2 to 2.2, and probably the 4 lower incisors to reestablish your incisal guidance at that point. Because when you intrude those teeth, you're going to have a gap. You're going to have interocclusal clearance, like those cases I showed, where I went back into ortho and rebuilt the teeth to finish the ortho. Okay, so there's a couple of things going on here. You know, the other main concern and question here that none of us have asked, because I haven't gone through my whole protocol.
Yeah.
How are you feeling? What do you want? Do you like your smile? Are you, you know, so we are looking at this very didactically right now.
Yeah, the airplane. Yeah.
Okay, so it all looks good, but I want to know how she feels after phase 1 appliance therapy.
Yeah.
If she feels better,
then
she's going to turn around and she's going to say, huh, okay, now I want to look better. Not that you don't look good now, but do you see?
Yeah, no, I am like
And I'm speaking from personal
speechless,
experience.
which is rare for me.
I would.
So now,
Yeah.
how are you going to approach your patients next week? You've got a whole new mindset. Remember, we talked about mindset, fixed
Yeah.
versus open. You're open. Okay.
I'm ready
We're
to
all
fight
we're all a
for
mix.
right now.
Okay, we're all a mix of mindsets. Okay, we're all a mix. We're all a mix, and you can't say I'm one and you know
Yeah.
the other. But this now, like. This is so cool that we were able to demonstrate this to one of the participants in the course, because this is what I see all the time.